again, it's a pleasure to present keynote lecture Jonathan Medved, the Our Crowd founder and CEO. And we wish you many more successes. Now you know that your heart is first fixed.
Thank you.
Okay.
Thank you.
Well. Now we're going to the fun part of the program, and we're switching to Sorokka Hospital in the south of Israel. Host, can you join us? We need a moderator, tough one, on the table. So switching to Sorokka Hospital for several very interesting, very unique cases. Sorokka, are you with us?
Good morning. My name is Dורון Zagar. I'm Director of Cardiology here at Sorokka University Medical Center. And it is our distinct honor and pleasure to host this presentation, this live case presentation to the ICI. I would like first to thank the organizers and in particular the chairpersons, Professor Lotan and Professor Bial, for the privilege of demonstrating this live case presentation in this prestigious Congress. We will demonstrate to you today 3 cases. The first would be a patient with severe aortic stenosis. The second will be a patient with refractory angina who is no longer amenable for revascularization. And the third patient would be a 91-year-old patient with critical triple vessel disease and LV dysfunction who will have complex PCI with hemodynamic support and intravascular imaging. So 3 different cases illustrating 3 different aspects of complex cardiac intervention. In the first case now, I have with me our whole team, led by Dr. Carlos Caffrey, Director of our Catheterization Laboratory. And I would also like to give special thanks to a dear guest and friend, Dr. Yaron Almagor from Shaarei Tzedek, who has been extremely supportive and helpful throughout the process leading to today's presentation. So without wasting more time, Dr. Caffrey, the floor is yours.
So, welcome everybody. Thank you for us. I just would like to present our team. First, here I'm with Miri Merken, the anesthesia, that is Dr. Nathaniel, Romy, Dudu, Nurit, Irit, and Karmit from the Shaarei Tzedek, and our good friend Yaron, that is helping us in this case. So we have a TAVI case, and we are going to give to our fellow, Dr. Luis, to present the clinical data of this case.
We have an 80-year-old female patient with a prior history of hypertension, dyslipidemia, and chronic bronchitis. She first presented with effort dyspnea about 10 months ago, which is progressively getting worse and has now reached functional class 3. She had a recent admission due to a non-STEMI, during which she underwent a coronary angiogram, which showed non-obstructive coronary artery disease. She also had an echo that revealed LV ejection fraction of 55% and severe aortic stenosis with peak velocity across the valve of 4.3 meters per second, a mean gradient of 54 millimeters of mercury, and a calculated aortic valve area of 0.9 centimeters square. Her surgical risk was calculated using the Euro score and STS score and was of about 4%. Despite this low surgical risk, she was deemed a poor surgical candidate due to a gravely reduced mobility and functional limitation after a hip fracture and surgery earlier this year. The recommendation of our heart team was for TAVI, and the patient agreed.
So,
Ask the panelists, everybody agrees with the indication, or are there any questions regarding the history of the patient? Marty, would you like to comment?
No, I think it's a very good indication, in fact. With someone like this who has difficulty with rehabilitation, I think with a percutaneous transfemoral approach, it offers particular advantages. Even though she falls into the category of between low and intermediate risk, I think it's appropriate. She's 80 years old, and certainly I think could benefit from this.
okay.
So we see. Yeah, go ahead.
I would like to show you here the CT of the patient. As you can see, the perimeter diameter is 23.5, and you can see on the right side that is actually a moderate calcified aortic stenosis with a calcium score of 2700 next to the follow-up slide. Now here you can see that it's not a real horizontal aorta, but the aorta is not vertical, and this is a good indication for implantation of symmetries. On the bottom you can see the height of the coronary. The left coronary is just 8.5 millimeters. It's relatively low, and this is another reason for the implantation of symmetries in this particular case. Let's, in the next slide. And here you can see the peripheral of the patient, actually very, very nice iliofemoral arteries with good size. And just now, I would like to show you a little bit what we did until this moment. We have on the table, please. If you can take move the camera here. We are on the left side with the 7 French. She's in the, with a picture in the non-coronary cusp, a pacemaker, and on the right side, we introduced yet the Lotus. She's 18 French from Boston. We have we can see the fluoro, please, at this moment. Can we change the screen and see the, okay, you can see 2 pigtails. It's a very nice trick to get the right angulation with less contrast, despite that we, of course, we had angulation from the CT. Just now we are with the safari wire into the left ventricle, and we are ready for implantation. Yaron, you want to say something about the symmetries?
Yeah.
We have a slide if you want.
First of all, thank you very much, Carlos, for having me here. It's wonderful, wonderful place, very good team, and it's a pleasure to be here. As Carlos said, we are going to implant today Boston Scientific neo-accurate valve, or what is called the cementis valve previously. Many of you which are not acknowledged well with this valve, this is a different type of implantation because it's a top-down release of the valve, which makes it, first of all, very stable during implantation, no need for rapid pacing, and the valve, which is supraannular, will open at the last part of the implantation, and really there is no need for stress during implantation since the old valve is working till the new valve is taking part. As you see it here, this valve has 3 parts, and if you see in the middle, what is written on the left, first we open the upper crown, second we open the stabilization arches, which is on the top, really stabilize and give orientation of the valve, especially when you have maybe a little bit of aorta, which is a lying aorta. And the third is the valve itself. So Carlos, let's go ahead.
You can move, all right. So what is neat with this type of valve is the performance of, keep the wire please, straight, with the performance of predilatation.
So Carlos is working,
So
and
are
what
you, are you doing pre-dilatation or not?
yes.
Oh, yes. We are
yes.
moving just now with the 20 millimeter balloon. Usually it's recommended to use a 1 or 2 millimeter diameter smaller than the diameter of the valve.
So with this valve, do you always have to pre-dilatate, or can you use it without pre-dilatation?
That's a very good question. Hi, this is this recommendation of the company is to do pre-dilatation, especially if you have medium to severe calcium. The reason for that is that the part that goes to the LVOT is rather softish. The radial support is not as we know for other valves like the Medtronic valve or Edward valve. And the part that goes under the valve really just help to anchor the valve, which is already anchored with the upper part of the aorta. Remember, it's a top-down implantation. So we are going now for pre-dilatation.
So the opening force of this self-expanding valve is somewhat less than some of the other self-expanding valves.
Exactly.
That may be part of the reason why the pacemaker rate is lower than many other self-expanding valves as well.
Yeah, that could be.
So Yaron, are you going to be using the small size? They come in 3 sizes. They don't use specific diameters, but size ranges. So is this the small that you're going to be using? Or
That according to CT measurement, Marty, this is medium, just at the beginning of the medium size of the valve. So we usually take the medium if it's in in a lower limit of the medium. So it's a medium again.
Yeah, actually, I think we recommend this using smaller balloon for pre-dilatation. In last 28 cases in our lab, we do not implant a single pacemaker because we're using normally 18 to 20 millimeter balloon for pre-dilatation. And yeah, of course, maybe this just by chance, but in last consecutive 28 cases, we do not implant a single pacemaker. I think we have to pre-dilate because this patient is 0.9 millimeter in square.
So are you using this valve in China, which means a severe calcification is not a contraindication despite the lower radial force?
Good. Yes, I think.
Marty, would you like to comment? Marty is shaking his head in his hands.
No, I think that this is it's a very easy to use valve. It's got low pacemaker rate. It's also got a short profile. So in this case, with a low left coronary, I think it's also a good device to consider. So I think it has a lot of attributes. But in the most heavily calcified valves, I think you do need to pre-dilate fairly aggressively to make sure that you get enough effective orifice area. It's slightly supraannular, but not as supraannular as other self-expanding valves like the Evolut, for instance.
Yeah, very good remark, Marty, about the lower left coronary. It's 8 millimeter, and this valve suits it well. So we'll go slowly for the implantation. Really, there is no need to rush. As Carlos really advanced the system, what is very important about this is to make slow implantation and to go on the archer curvature or the V curvature before you enter the LV. And as you see here, he's going on the outer curvature. Okay, this is very good. A bit more. A little bit more. Okay, let's go to 15. I will. Don't move your hand. Okay, so what you see here, it's really not hard to see. You see the pigtail, and you see 2 or 3 dots just at the inferior part of the pigtail, which is sitting in the non-coronary cusp. This is a marker of diffusion of the lower crowns just before it enters the LVOT. So this is very good. We will make for you a short injection. Let's go. Okay, you really see it really nice. At this point, pressure is good, pre-dilatation was done, and let us, of course, show you the release, which is very slowly at the beginning. Okay, we just release the upper crown slowly. Miri is doing it. Carlos is holding the system firm, and we take our time. There is no need to rush again. Okay, stop here. So let's take a picture. You see the upper crown is open. We take a picture. Again, we are very happy about the positioning of the valve itself. You agree, Carlos?
Yes, it's very nice.
Okay. Second is the release of the arches, the stabilizers, and this
device open the upper crown first.
Exactly.
Yes, exactly.
Wait.
I do not have experience with this device. Normally, I think when the markers of the lower crown may be, according to the self-span, is too low. I don't know, maybe this device, you open the upper crown, maybe it will fix.
Okay, so I've said at the beginning, sorry if you missed it, it's up-down implantation. So first of all, we open the part that is in the aorta, and second, we release the valve. Okay.
Do you don't think that you're a little higher here?
No, look, you want another injection?
Okay,
let's do that.
Again.
Okay, Carlos is holding firm. I think we are perfect.
Okay, so we'll continue.
So she's, okay, Miri is going to release fast. Fast. Very good. Till the end. Okay, so now, as you see it here, the old valve is still working. Can you show us the pressures, Erez? Pressure, okay, you see that. Pressure is very stable. Old valve is working, new valve. Let's take another picture, Carlos. Okay, it's only 5 cc.
Stabilizing arches help to orient the valve in a more coaxial position.
Exactly. At this
and
point,
see now he's gonna push down a little bit as he releases the lower crown, which is gonna open the new valve.
Wait.
Yeah. Okay. So at this, we leave by the way, the pigtail inside. We'll take it out with a wire. You put a little bit of pressure here. That's beautiful. And you open fast. Show. Fast. Very good. Till the end. Okay. So at this point, the new valve is functioning. The old valve is gone, obviously. Still, we have all the system inside, and you see the pressure is holding really nice. So we will take out, I will help you. Hold this one. No. Need it. You see, I play with the wire. Just bring the wire a little bit to the LV.
Very careful.
Get it,
careful.
the system, okay.
No.
All right. We just go to the aorta.
Okay, give me the wire.
To close the valve.
To take the picture out.
Wait, you have to close the valve.
Mm-hmm.
We leave the wire inside. The reason is that if you need to do post-dilatation or for other reason, it's much better to have the stiff wire inside because sometimes it's not so easy to get the new wire inside. So let us show you the closure. Yes, Stein. Okay. Take, you see it with us. Can we see the fluoro?
Yeah, we see it.
Ah, very good. Okay, close it till the end. Very good. So there are only two steps. Mary is closing it, and you see it's going to...
Well, be careful with the safari, please, with the wire.
Okay, close it. Very good. Now it's closed. We can take out slowly, slowly, no rush. Leave the wire inside.
It's an important point that you have to really be careful with the wire, because if you lose wire here, you have really a lot of problem to cross through the arch and to be sure that you are in the real lumen.
Now, as you know, pacemaker rate is really low with the cementis. This is what Marty said about the pressure of the side that go into the LVOT. The pressure is low, so most probably that's why it's a lower pacemaker rate.
So
now, Carlos is going to take out the pigtail with a wire. Be careful,
You know, the
Carlos, there.
diastolic pressure looked fine, but how do you assess PVL, Yaron? Are you going to do an aortogram?
Yes. Okay, take the wire out. Wire out.
So while you are doing this, remind me, what is the sheath size, what you need for this valve?
Should be 18.
18?
Yes.
And can you use it without sheath?
Okay. One moment.
Does anybody know that? Can you use it without sheath in case of small? No. Everybody is shaking his head?
Okay.
So we heard about the advantages of this valve. It looks very straightforward and easy. There must be some limitations as with all other valves. So what are the problems you have encountered?
So one of the limitation is, of course, the size of the sheath. Actually, we are using an 18 French sheath, as actually you have to be really careful with the peripheral arteries of the patients and to select carefully the patient to avoid vascular problems.
Okay, guys, before we go to the second room, we'll make an aortic shot. Remember, we have the stiff wire inside. Go.
Okay, very nice.
Looks nice.
That looks very good.
Yes, always be some AI because of the stiff wire. But as you said, the diastolic pressure is more than 60. So I think we are safe.
Okay, I think that we can exchange this stiff wire and to put a pigtail inside and to do another injection and to see if really we have a AR here or not.
So,
but it looks good anyway, so there's trivial IR, if at all.
Anyway,
I think it looks good. Congratulations to a good case.
Yeah, it's a very easy implantation because you don't need really to suffer of rapid pacing during implantation, and this is very good for low LVEF. And I think what Carlos said, the downside so far is big sheath in old people in the leg. This is something to be fixed.
On the other side, with this particular stem, a valve has been described the rate of maker implantation and lower that exists, less than 3%, and no case of coronary occlusion in the registry of this with this valve with more than 1,000 patients. So a lot of advantage And of course, nothing is perfect.
Can you explain until which stage of the procedure you can retrieve the valve?
No, you cannot retrieve the valve.
And the early stage, when you have not released the upper part, is it still possible at that time?
You can, of course, implant the valve if it's not in place, but it's not retrievable. One thing which is important to say, at least in my experience, I had 2 cases where I had to put valve in valve for not very good valve implantation location, and it went very, very well. One was with the Cementis valve, and the second was with the Edward valve.
Let's see. Do another injection.
So Carlos, no.
We're doing just another.
Okay.
Okay, just minimal AR, and probably the nitinol is going to complete the work during the next minutes. You are happy?
Yeah, very happy. I think still you have the pictal inside. Diastolic pressure is very good, over 60. So I think we are done here.
Do you skip the echo? Echo is not important anymore in your hands?
We actually don't do, of course, TE. The patient is in conscious sedation, and just we keep the echo beside in case of some emergency, as the patient is going to undergo a new echo just after the procedure in the intensive care, not now.
How often do you have to post-dilate with this valve?
It has been described more or less 25% of the cases. In our particular experience that is very, very short, we did just in 1 case.
Will this be helpful if you have an echo, for example, to see the perivalvular leakage, or because how severe, and to decide if we need post-dilatation?
Well, I'll tell you what, I think it's very important that if you see mild AI, still remember it's a self-expandable valve that will expand more, and you take measurements of pressure. I mean, if you exchange severe AI with very low AI with a diastolic pressure of 60, I think you are done here. There is no need to go ahead and do more than that, at least in our experience. If the pressure was low, indicating more important AI, we would have done post-dilatation. Do you agree, Carlos?
Absolutely. Actually, not just in this valve, in the other valves, we are basing our action just on the angiography and just in special cases. But again, just for safety reasons, we do an echo. If we need to do a post-dilatation, we base our action on the angiography only, and the hemodynamic, of course.
Yes. Okay, guys. So we had our 25 minutes that you allowed us. I would like to thank personally the people here.
Thank you.
And we'll go to the next room because extremely nice Israeli-made case. So we can move to the second room, and thank you again for your comments. Thank you, Carlos.
Thank you.
Thank you again
Miri.
for a great case demonstration.